right, guys, today's topic is a little different than normal. It is called When Asking for Help Isn't Enough, the Lindsay Clancy case in the mental health system. It's going to be a little different than what I normally do, but it still sticks to the heart of this podcast, which is we need to be having these discussions that systems don't have, and they need to be real, genuine, authentic discussions. I wasn't going to talk about the Lindsay Clancy case. I've been following it, but I just felt like I wanted to kind of see where it went. And I was actually a little late to the game. I'll be honest. I heard about this on TikTok and was like, this sounds like something that would interest me. So we're going to kind of go down the rabbit hole. And I did. I had pretty much decided that I still wasn't going to talk about it because the case hasn't played out. But as I have watched this case unfold, particularly the testimony surrounding Lindsay's mental health treatment before the deaths of her children, I just kept coming back to it. And last night I was laying in bed and I was like, okay, it's time. It's time. Given some of the things happening in my own life, I've realized that this is exactly the conversation I need to have right now. Because for those of you who don't know me, I am in my own legal battle over mental health systemic failures that I believe occurred. We're still in litigation. However, before we go any further, I want to make sure that we remember at the end of the day that there are three names that need to come before everybody else's, and that is Cora, Dawson, and Callan Clancy. These three beautiful children lost their lives, and nothing we discuss today is going to change that. Nothing about discussing their mother's mental health is minimizing their death. This is still a tragic loss. And nothing I'm going to say today is intended to determine whether Lindsay Clancy is guilty, not guilty, legally insane, or criminally responsible. I am not the judge. I am not the jury. I'm not her defense attorney. I have no stake in this game other than to open up the discussion surrounding the bigger picture, which is, did the mental health system fail her? Did the mental health system fail her and also fail her children? Because they're byproducts of this failure, potentially, allegedly. I want to make it clear that I am not an attorney. I am not sitting on the jury, and my goal here is not to try a criminal case on a mental health podcast. That's not what we do here. The defense is arguing that Lindsay was suffering from severe mental illness, including postpartum psychosis. The prosecution is disputing that explanation and arguing that her behavior demonstrates planning and criminal responsibility. That is for the court to decide and the jury to decide. What I want to talk about is something just a little bit different. I want to talk about what happened, the events that took place before January 24th, 2023. Because the more I've learned about Lindsay's interaction with the mental health system, the more I keep coming back to one question. How many times does someone have to ask for help before we recognize that they desperately need help? What happens when someone does exactly what we tell struggling people to do? They reach out, they talk to somebody, they see a therapist, they go see a psychiatrist, they take medications, they call the crisis line when they're in crisis. They go to the emergency room when they're in crisis. They voluntarily enter a psychiatric hospital or attempt to enter a psychiatric hospital. What happens when somebody tries to do all of those things and somehow we still end up here? That's the conversation that I want to have today. Before we get started, I have a little bit of housekeeping and some disclaimers to go through. My name is Jamie. I have a bachelor's degree in psychology, a master's degree in Christian counseling of substance abuse and addictive disorders. I received both of my degrees at Grand Canyon University. and I completed my internship for addiction counseling licensure in the state of Arizona at Arizona State Prison. I had an active license for only about 3.5 years before I had a midlife crisis and realized I wasn't what I wanted to be when I grew up. During the December 2021 pandemic era, I began taking care of my grandmother who had dementia, and this really contributed to my midlife crisis mode. Also realized that I got tired of arguing with insurance about justifying a stay, which is a big part of mental health. When insurance is involved, you have to justify the care. And it was just beginning to be a little bit too much for me as somebody who struggled with mental health and somebody in recovery. I realized I would rather tell my story through writing. And I published my very first book during the pandemic called Memoirs of a Black Sheep. I feel like I provide more value to my audience as somebody who understands the system and has been through the system than as somebody who is part of the system. I somehow stumbled into quitting my job to write full time, into TikTok and social media and podcasting. And well, here we are. I just also want to make it very clear that I am not a licensed therapist anymore. I am no longer licensed at all. But even if I was licensed, I could not be your therapist because I'm just some random chick on the internet talking about mental health. I don't expect to be discussing anything that's really over triggering because I really don't like talking about graphic things myself. However, if you feel like for your own well-being, this might not be the episode for you, I fully support taking care of yourself. I do like to give that trigger warning just because sometimes I don't know how these topics are going to go. And even though I do kind of bullet point out what I'm going to discuss, sometimes it takes a direction I'm not expecting. I don't expect that to happen today, but it can. If you feel like you're unsafe at any time, whether now or in the future, I highly recommend that you utilize the 988 crisis line. If for some reason that crisis line fails you, or you just feel like they didn't do it for you, but you still feel like you're in crisis, I'm going to encourage you to go to your local emergency room. If all else fails, I want you to call somebody who can sit with you and help keep you safe. If you are struggling with mental health issues, suicidal thoughts, any of that, okay? I've been there and I fully support getting help. While I'm in my own legal battle as a pro se plaintiff about mental health care that I feel failed systemically, I am also not an attorney and I do not pretend to be one, not even on the internet. Okay, so nothing here can be construed as legal advice. Nothing here should be considered a substitute for therapy. I fully support getting on the internet, Googling people who are credentialed in those things if you need them, because while I do hold the education, I do not hold the credentialing, and it would be unethical and inappropriate for me to be doing any kind of therapy or advice on the internet anyway. Okay, now that we've gotten that out of the way, hi, welcome. We are going to dive into the first part of this conversation, which is going to be, we always tell people to get help, right? We always tell people to get help. I am a mental health advocate. Then when I left the field, I decided I was going to advocate for people with mental health struggles or just for mental health changes in general. My goal initially, when I first quit being a therapist, was to normalize the conversation around mental health. I am so tired of mental health and addiction being stigmatized and shamed. None of us are perfect on this earth. None. I have said the following words countless times. Get help. It's okay to not be okay. Call somebody. Call the crisis line. Reach out. Have you talked to your doctor? Have you tried therapy? If you're in crisis, go to the hospital. And I'm going to continue saying those things. I will. I'm never going to stop saying those things. But I have become increasingly uncomfortable with the way our responsibility sometimes seems to end right there. And with I mean all of us. I mean, whether we're providers, peers, because I feel like we put an enormous amount of responsibility on the person who is struggling. Recognize that you're sick. Find a provider. Make the appointment. Show up. Tell the truth. Take your medication. Follow your treatment plan. call if you're getting worse, call the crisis line, go to the emergency room. We tell patients to do all of these things. But there's another side to this equation that we do not discuss nearly enough. What is the responsibility of the system after a person actually shows up like they're supposed to, like we tell them to, like we encourage them to? Because access to mental health treatment and receiving effective mental health treatment are not necessarily the same thing. I feel like the Lindsay Clancy case forces us to really confront that distinction. I want to talk about how Lindsay Clancy did actually seek help, like we tell people to do when they feel like they're struggling. When I say Lindsay Clancy asked for help, I don't mean she mentioned it once when she was feeling down or just having a down day. According to the evidence and the testimony that have been presented during the trial, Lindsay had substantial contact with the mental health system before January 24th, 2023. She interacted with multiple outpatient mental health providers, and she was prescribed numerous psychiatric medications. She contacted crisis resources, and she even went to an emergency room. She also attempted to access a specialized hospital-based day treatment program for women experiencing postpartum mental health problems. She was not admitted into that program. Eventually, she voluntarily admitted herself to McLean Hospital for inpatient psychiatric treatment. As of the time of this recording, which is August 16th, 2026, the evidence presented at trial has also shown that Lindsay was conducting internet searches related to her mental health symptoms. And according to reporting by the Associated Press, those searches included subjects such as hallucinations, psychosis, medication side effects, suicide, and ways to die. None of these facts prove that Lindsay was psychotic when she killed her children. They don't prove that a particular provider committed malpractice, and they do not prove the insanity defense. They also don't answer the ultimate question, because that is for the jury to answer. They do establish something incredibly important for the conversation that I'm having today. Lindsay Clancy was not someone who was completely disconnected from mental health care. She was seeking help. And that leaves me asking, what happened inside that system? Some of the information that has come out has just absolutely left me mind blown. As somebody who's been on the receiving end of psychiatric care and therapy, the medication aspect, I guess, is just wild. And I've heard about certain conditions taking lots of medications. I have observed it passively as a patient, but most people that I know, it took a long time to get to the amount of medications they were on, and it took a long time to figure out what medications worked, and they also had to be very careful about interactions. And I'm not alleging anything by this comment, but just in my personal opinion, it seemed like there was a lot of medication changes in a very short period of time. What works for one does not always work for the other. We're all unique in our genetics and our genetic makeup. However, I would think that most providers want you to try something for a month or 2 months unless it has an adverse reaction without changing or adding things to it, because it's much easier to rule things in or out if we go slower. And that's just my experience. I'm not qualified to judge this. It just feels very quick. And when you hear what I'm about to say, you're going to know why I'm saying that. When we talk about the medication, the numbers here are quite striking. According to the Boston Globe review of court records, Lindsay Clancy was prescribed 13 different psychiatric medications over approximately 4 months leading up to the deaths of her children. The Globe counted more than 30 prescriptions, and those prescriptions involved multiple healthcare professionals and multiple treatment settings. Now, I want to just stop there for a second. I want to revisit this. 13 different psychiatric medications during 4 months leading up to the deaths of her children, and the Globe counted more than 30 prescriptions. Now, I don't know if that means 30 prescriptions for 30 different medications or just 30, over 30, including those 13 different prescribed. We're not going to get too caught up in that, but that's still a lot. I'm not a psychiatrist. I'm not qualified to discuss medicine like a psychiatrist or a pharmacist. And I am not going to sit behind this microphone and tell you what medication should have been prescribed because I'm not qualified, but I also don't know the patient in this sense, which it would be Lindsay Clancy. I'm not going to tell you what medication shouldn't have been prescribed for the aforesaid reasons, because medication can be life-saving. It can be life-saving, and I know there's a lot of controversy around SSRIs. I can tell you for myself, if I was not on them, I'm not sure that I would be here. And maybe they're not for everybody, but I can tell you if I don't take mine, I'm not in a good place. And I've tried diet and exercise and structure and everything else. Okay, so for those of you who are like alternative medication people, I'm not going to shame how you live your life, and I don't think you should shame others for how they live theirs. Psychiatric medication can be life-saving. Psychiatric medication can be incredibly important. And sometimes finding the medication genuinely requires trying to find different medications. And that is the trial and error process that I just discussed a few minutes ago, where sometimes you start one or two, and then, you have an adverse reaction. You try to figure out which one gave you the adverse reaction, or you find out which one's working and you try to, make sure you stay on that or increase the dose, or however your prescriber determines that process. From a systems perspective, I absolutely have questions. When multiple providers are treating one psychiatric patient, who is looking at the whole medication picture? And the reason I ask this is because now I'm somebody who gets seen in the VA hospital. One thing that they do for us, and I don't know if this is the norm everywhere because I've been seen at the VA now for so long that I don't know any different. I went from the military to the VA for healthcare. Prior to that, it's been almost 20 years since I've had like civilian healthcare. So we're just going to be honest with that. But with the VA, one of the things they do is they provide us with a medication list that we can take to any provider if we go outside of the VA. So that way, whatever provider we go to can see what we're on. And then here locally, I'm in a rural area. They also offer the ability for us, if we opt in, to share our medical records with our local hospital. So that way, if we have to be treated in the local hospital, they're able to see our medication list as well. I know it's not this way everywhere, and I know that having the online ability to see records has changed some things, but I do think that most providers are going to ask you if you're being seen somewhere else and if you have a medication list. And even if you don't, I believe they can sometimes call the pharmacy. However, that's where our pharmacists step in, right? Let's just say that I don't know that you've already been to 5 other people for a prescription, and this isn't narcotics. Okay, so it's not like you're on a list because you got narcotics and you can't get more for so long. It's not tracked by the DEA. Okay, so this is completely different. So I'm going to provider A and I'm getting Seroquel. And then I decide Seroquel isn't working for me, so I go to provider B, and they're going to give me whatever, I don't know, Zyprexa. Okay, Zyprexa. But the person giving me Zyprexa doesn't know that I'm getting Seroquel. This is where the pharmacist role matters, because it sounds to me, and I could be wrong, but it sounds to me like she had a central pharmacy where she was picking up her medication. I want to say it was CVS, but I don't know. Don't quote me on that. This is where the pharmacist will oftentimes go, oh, these could counteract each other, right? And I'm not saying that that's what happened, but I also have to wonder, and I know because of HIPAA, I don't know how this particular issue would work, but I would think a doctor could check with the pharmacist to see if there's any other medications that interact, because that is a need to know basis. And I would think that it's important to know so we don't. And with that aspect, I don't know enough about it to understand how it works, but I do know that pharmacists play an important role in seeing if a prescription is written wrong. You know, if you give somebody triple the dose of Seroquel and they've never had it before, and the pharmacist meets with the patient and is like, hey, you ever had this before? And they're like, no, that's where the pharmacist can go, I think this might be too much. Check with the doctor. I would like to know what role that plays in this whole picture, but I don't think they've even addressed that during this trial. However, most providers are going to ask you for a medication list, or at least ask you to list what medications you're on. Now, one of the biggest issues that we have in the mental health field, sometimes people don't know their medications, sometimes people forget, sometimes people don't want to tell a doctor something. They think they're going to get judged or they're going to look a certain way. And it's the same way with suicidality. Sometimes I'm not suicidal. If a bus hit me, I'm not going to fucking move out of the way. And so that's where these conversations get very nuanced and very complex. I think these are the things that the defense is trying to look at. We have the prosecution, who maybe the prosecution doesn't understand how mental health system works as a whole, because when you think about it, what we know, if we've never been treated in mental health and never been around somebody who's had a mental health issue, is very, very limited. But when you're somebody like me who's been in mental health as a patient and a provider and has family members that are in long-term mental health care, like, it's very easy. It's a language I can speak. But if I'm a prosecutor and I know law, maybe I don't understand the mental health aspect. So I'm going to give them a benefit of the doubt. I am going to say they're not likable women. I do feel like there's a lot of trauma farming going on. But at the end of the day, I think people forget they see a lot of really ugly shit as part of their jobs. And that doesn't minimize or take away from anything they've done that people dislike. The same way that mental health issues don't minimize what happened to the Clancy children. Okay, because no matter what, at the end of the day, those are the three people who lost out the most in all of this. They were innocent bystanders. They were innocent bystanders in this entire failure, whether it was just mom or mom and dad or the system or however you want to see it. Those three children cannot be forgotten in this process. And this is why I am so passionate about this topic. Again, who is looking at the whole medication picture? Who's monitoring changes? I know with my providers, even my VA provider, who they're always super booked, we will meet about quarterly if everything's going okay, but I always have the ability to message her in our EHR. It sounds to me like that's even something that Lindsay tried to do with some of her providers. And I don't know if they responded back. I'm not really sure. The testimony was a struggle for me to get through, but I will tell you that the one provider who, I think it was Dr. Tufts, I think she did not represent very well what we expect the psychiatrist to do. I'm not going to say she had any wrongdoing. I'm just going to say, in my opinion, she did not represent very well what we would expect of a psychiatrist. There is so many things that go into mental health. We do at intake a biopsychosocial workup. We want to know everything we possibly can about you. We want to know about your health conditions, what's your environment at home like, are you working, are you not working, what stressors are you dealing with? She had her third baby and she felt like she was struggling with postpartum depression. That's an important factor in this piece because hormones play a role in our mood. In fact, there are some who would argue that hormones play more of a role in our mood than serotonin. I'm not qualified to have that discussion, but I do know as a female, my hormones played a role in my mood. And I can say that as a female. I want you to think about how much your hormones change after you have a baby. I've given birth to 4. I have cried after every single one because that's that hormonal change, right? That was temporary. Think about having a baby. You're just completely drained from that experience itself. The fact that a baby requires 24-hour care, especially in the beginning. They're waking up every couple hours and you're feeding them, and you feel like you're tired, they're tired, you've got the hormone changes, and if you're breastfeeding, maybe the hormones stay up a little bit longer, and if you're not, maybe they don't. You just had this baby and you are maybe emotional for months and months and months afterwards, which is what it kind of sounds like happened with Lindsay. And this wasn't her first baby. This was her third. It's very clear she was struggling because they had brought her parents into the home. They brought her in-laws into the home. They had a nanny. I just wonder, did anybody ever take that into consideration when they were assessing her? There were some really well-versed providers, and there were some that it was very hard for me to watch. If I view somebody as incompetent, I struggle with them. I also have a struggle with people who I think are competent and they continue to make mistakes because it feels reckless and not because they don't care. Maybe they're cutting corners. I have this super passionate thought of, and I have to remind myself all the time, not everybody operates like me. However, when you're a psychiatrist, you're a psychologist, you're a mental health provider, do you know that what you do is just as important as a person who's flying a plane? You have people's lives in your hands that you don't even know. At the end of the day, is Lindsay Clancy the only one responsible for the loss of these children? I feel like the system failed her as a whole. And I'm not going to name this person and that person. We're not going to go off on the Patrick did it theory. Patrick's not on trial. I'm not saying he shouldn't be. I'm just saying he's not on trial. We need to be looking at the facts as both sides are presenting them. The fact of the matter is, regardless of whether you're on the prosecution side or the defense side, I think it's very apparent to those of us who are watching the trial, there was a lot of freaking failures. Who is looking at the whole medication picture? Who's monitoring those changes? Who knows what the others prescribed, right? And that's why I talked about the pharmacist. Who is asking whether a new symptom started before or after a medication change, which is why in my experience, and I can only speak for myself on this, whenever I've needed a med change, we always only change one at a time. These are just examples, but if I'm taking Wellbutrin and Zoloft and I'm having more anxiety, okay, let's taper down the Wellbutrin a little bit and see if that's it. And if that doesn't work, then we'll try the Zoloft, or we'll, switch something around. My provider will say, okay, let's try something else. She likes to give it time for it to chemically change. I think that's important. It all goes back to trial and error. What symptoms started, what symptoms changed when we did this. It's like when you were trying to figure out allergies, right? And you have to start eliminating things one by one. Was it this? It's the same process with medication. And it's the same process with medication in general, to my understanding. Who is distinguishing symptoms of the underlying illness from potential medication side effects? I don't feel like this has been addressed enough in the trial. Let's just say I'm sitting on the jury and I have no knowledge whatsoever of mental health. I need to know if that could be a medication side effect or if that could just be a side effect of mental illness. Mental illness presents on a spectrum. I want you to think about schizophrenia for just one moment. The schizophrenia that we always see portrayed in TV and movies is always on this really far end of the spectrum. And it's always this violent person who won't take their medication. They don't actually talk about how the average person with schizophrenia who's being treated with medications is actually baseline normal. And maybe they have flare-ups or breakthroughs. There's some people who they don't need medication. They've learned to understand that that thing in their head is not real. I've met people on both ends of the spectrum. I've met people with the violent thoughts, but not the violent behaviors. I've met people who they know there's a voice there and they just ignore it. Okay. So, but you have to think about, most people don't understand that. And I will tell you, when I first started practicing, I was actually afraid of people who had been diagnosed with schizophrenia because of the way the media portrayed them. Then once I got to know people with this condition, they're just people like me. They just have this chronic illness. Mental health is a chronic illness. Like people who struggle with bipolar or schizophrenia, that is a chronic illness. Just like lupus can be chronic. I think people don't really recognize these nuances. I also think that sometimes agitation and anxiety might be part of a psychotic episode, but they could also be part of a medication side effect. And that's why it's important to document. And sometimes the patients can do it, sometimes the doctors can document it in their notes, the providers, whoever's seeing them. I'm noticing increased anxiety. That's why we do these scales, these GAD scales. What is your anxiety level? Because it's a measurement. Are they getting worse? Are they getting better? Can we notice if this month it got worse and they've been on this medication? It's a process. I saw this woman on YouTube yesterday. I think her channel's called I Don't Belong Here. One of the things she said was that a lot of the things that they're discussing in the trial in and of itself is a side effect of mental health issues, is not necessarily being forthcoming with suicidal ideation or reporting symptoms differently to different people. They were terrible historians. When you have trauma or you have schizophrenia, you have moments where you're not lucid, your timeline is not the same as everyone else's. There are times where people with trauma will go hours and feel like it was 5 minutes. And there are times where they will go 5 minutes and feel like it was hours, and then we'll describe that to you. We can't even say that Lindsay Clancy was manipulating the system. In the mental health side of things, people don't always remember the same things, or they contradict themselves. And it's not intentional. They're not trying to lie to you. They remember something with you that they don't remember with somebody else. And one of the other things she said in her video was, as a provider, if I saw you more than twice, I remembered you. Thank you. Yes. And if I did your intake, I definitely remembered you. If I didn't do your intake, but I saw you more than twice, I definitely remembered you. The other thing she said was, we don't always write every single thing in the note. No, we don't. We write the things that cover our ass and cover the patient's ass. I'm not going to say Jane came in for therapy and we discussed XYZ and XYZ in great detail. I'm going to say Jane came in for therapy today and we discussed her relationship issues, and we discussed ways that she could reframe maybe her low self-esteem that's affecting her relationship through cognitive behavioral therapy. You're talking about what you did in the therapy, what their issue was at the time, and then you're going to do a mental status exam. Were they oriented ×3? Do they know who they are, where they are, and what year it is? Do they present normal and clean? Do they present disheveled? Do they present anxious? One of the things I've noticed Mr. Reddington has done, he's really attacked the telemedicine. And there's some truth in that because, and I can relate to this, I'm telling you, I've done telehealth as a patient. I'm seeing my prescriber. It's not as big of a deal because I'm stable. But if I'm really in crisis, you probably should be seeing me in person. Even as a counselor, that is difficult to gauge through telehealth is going to be some of those symptoms you're not going to see, because look at me right now. If you're watching on YouTube, you only see what I show you, right? You only see my hands if I put them up here or anything else. Can you see my legs shaking? No. You might see my legs shaking like this, but that could just look like, you might not be noticing that as a therapist, but if you're in person, you're going to notice because the chair is squeaking or the table's shaking. I'm the kind of person where if I'm physically in a room with somebody, I can actually almost gauge their emotion. Like, are they tense? Are they happy? Are they joyful? Is that anxiety or excitement? And it's all partly based on body language. And one of the things that Mr. Reddington has addressed in this trial as well is, was she even being properly assessed in some of these sessions because they were telehealth? Telehealth is great in a pinch. Telehealth is great if you're stable. But if you were coming to somebody with a struggle day after day after day, it might be best to tell them to come into the office. Just my opinion. I don't know what the circumstances are for any of those places that were providing her services. That is why it's important to understand what is the symptom of the medication and what is the symptom of the mental illness. If I see you in person and you're always shaking, and then I see you telehealth and you're shaking, then I'm going to assume you're doing your normal leg shake from anxiety. If you're starting a new medication, I may not notice those subtle differences, and that's it. The subtle differences are more apparent when people present in person as opposed to telehealth. I also think it makes it harder to tell if treatment is effectively working when we are meeting via Zoom, who is watching the trajectory? And that is why these assessments are important. It's crazy to me because I've seen some places that you get an assessment every session. And then I've seen some where they'll go someone's entire therapy history without an assessment. The last place that I worked, we did assessments at intake, and then I personally chose to do them at least once a month because I wanted to see if somebody was getting better or not, because it made it easier for me to justify to insurance their stay because I had these assessments. We would assess people before they were discharged. If someone was really severe, we might assess more often. If we had somebody who maybe was a borderline personality and they were a cutter or a self-harmer, we might assess every single session. Just the way I operate, this does not mean anyone else is wrong for how they operate. If Lindsay Clancy would have been my client, we would have done an assessment every single meeting because of how she was feeling. One of the biggest battles I had as a therapist, which is one of the reasons why I was like, okay, I don't want to do this anymore, is fighting to justify somebody's stay. The insurance will jump over a dollar to save a dime. They would discharge people before they were ready just because they showed a little bit of stabilization. It is normal for somebody with a mental health issue, especially the more severe types, might be stable for a while and then they have this dip and then they're stable again for a while. The insurance doesn't recognize that. They're trying to fit all of these round people into square pegs. That's really it. I had a client who they had not stabilized until at least 2 years after they had been in treatment. They had only stabilized maybe 3 months, and insurance was like, okay, they've got to go. And it was like, okay, but we need to see like a pattern of stability. 90 days is not enough. And I sat that patient down and I did every assessment I possibly could for that patient. And then I wrote up this big summary based on the results of all of that, submitted it to the insurance, and they said, oh, can stay another 30 days. And that was all we got out of it. And basically, this is it. We're not going to extend again. And that was like one of my biggest frustrations. And I feel like that might have been one of the issues Lindsay Clancy ran into. I don't know if she had insurance or if she didn't have insurance, but I do feel like this system is so taxed that they're just so quick, like, oh, you're doing better, bye. And what it's actually doing is it's creating a greater tax on the system, because instead of actually giving people time to show stability, we're booting them out as soon as they're stable, and then it becomes a revolving door, which is actually contributing to this roller coaster. Just my opinion. I'm an anomaly. I went to rehab for 4 months. I did struggle along the way. I only had to go to rehab once. I personally think that most change takes 2 years, and the people should be in rehab for 2 years. And I think if they did 2 years, we would have a lot less people going in and out of rehab, because 2 years is going to give them time to really rechange all of those habits. I think the same thing for mental illness. I think sometimes for some people, it can be 3 months. For some people, it can be 2 years. But for the most part, it seems like the system, and by the system, I mean insurance, they've shown 3 months of stability, they've got to go. Well, not everyone is going to be fine after 3 months. Some people panic because they feel pressured, and then they go back and they decompensate. As you can see, I'm very passionate about this. This is why those assessments matter. Who's watching the trajectory? If somebody is presenting to me with suicidal ideations and they're afraid they're psychotic or they're not sleeping, we're going to be doing those assessments because it's easier to determine. And if we are all in the same network, other providers can see that information. In that aspect, I will give these different providers that. Maybe they weren't all in the same network and they didn't all have access to her records because of the way HIPAA works. Going back to the trajectory and measuring these scale systems of measurement, at what point does someone say, this isn't working? If somebody is repeatedly presenting to you that they are struggling and you're of the opinion that they are not malingering and they're not suicidal, but they do say that they are in crisis, at what point do we say this isn't working? We need to reassess this entire picture. I know she's not suicidal, but she's in crisis. How do we get her inpatient? Because continuing the treatment outpatient is clearly not working effectively. And continuing treatment isn't necessarily the same thing as receiving effective treatment. She can continue outpatient treatment. If it is not working and her outpatient team is saying she needs a higher level of care, that needs to be seriously considered. Ineffective treatment could end us up in some very dangerous situations, and I think this case is a big example of that. It's sad, and every time I think about all the people this impacted, I don't think this has just impacted her kids and her family. I think it's impacted a lot of us, especially those of us who are passionate about mental health. The whole point of us who went into this field wanting to help people, because we don't want these things to happen. I hate to say, but I think we do get jaded and bitter because we see that we are gaslit by the system as providers and as patients that no, this is just the way it has to be. Might have been the reason 3 kids lost their lives, because nobody thought she was appropriate for a higher level of care. Lindsay Clancy honestly shouldn't be the only one being picked apart for this. I think that there's a bigger picture and people really need to examine all of the failures. I do understand that the family is in litigation. I don't know if it's with the providers or the hospital. I absolutely would be too. When something is preventable and you see a client decompensating and you don't take the steps, that comes back on you. And I used to always say, I can get a new job, I can't get a new license. If the system is not going to work for my client, I will advocate and I will document every attempt at advocacy. I'll be damned if at the end of the day somebody's going to sue me because I didn't do my job. I will put so-and-so declined to blah, blah, blah. Higher level of care recommended, insurance declined. I did not want that coming back on me because I understood that I had people's lives in my hands. I'm not trying to tout the moral high ground. That was ingrained in me. I completed my internship at a prison, and my supervisor for that internship ingrained in me, cover your ass, cover your ass, cover your ass, because you can get a new job, you can't get a new license. That was the best lesson she ever taught me. She said, you want to put who you talk to and why. If you recommend something and somebody says no, you want to put, if somebody is suicidal, homicidal, you better put that risk assessment. You better put that risk assessment and all your recommendations and who you talk to. And if you talk to a supervisor, because if you end up in court, you need to be able to explain all of those decisions. For me, that's why watching this from the outside, it just blows my mind. I only have a master's degree. I only specialized in addiction counseling. The fundamentals of many of these things are exactly the same. You have a duty to warn, you have SI and HI processes, like evaluation processes that are the same. The GAD-7, the PHQ-9, the SASE, the CSS, the Columbia Suicide Risk Assessment, those are all essentially the same, no matter your level of education. The only difference is some people went to school to be a medical doctor so they can prescribe. Some people went to a doctorate school to get greater education, could get paid more. They invested a lot more of their time into this education, but the basic fundamentals are the same. The point is the safety procedures itself are the same. The documentation is the same. You should be accurately reflecting in your documentation as a provider what you provided. And I can tell you, if you called me to testify, even now, and I have not been a therapist since I voluntarily surrendered my license because I was having my own mental health struggles in the middle of my midlife crisis, and I own that. And I could have kept it in suspension status and done continuing education, and I was just like, no, I'm so determined. If I want to go back into the field and I need to do more classes, I'll just do more classes. I'm okay with where I'm at. However, if you were to call me to testify on any one of my clients, and I've probably had at least 200 to 300 over the course of the time I was a therapist, I would only need to look at their chart once to refresh my memory. And I don't have that great of a memory. I would only need to look at their chart once. If somebody said, can you look at this chart and refresh my memory on this, this, and this, I could tell you, oh, yep, this person, they had borderline personality disorder, and we had to recommend a higher level of care because XYZ happened. This person had a substance abuse issue, and they did not have the support at home that they needed, so they were struggling with relapse. Maybe because I was a baby therapist for so long, that's why it's easy for me. It's hard to believe that somebody who was in constant contact with Lindsay Clancy, and it was actually still relatively new within 3 years, right? That she's on trial now. And they can't remember many of the things she talked about. That's crazy to me. I got called to testify in somebody's hearing after I wasn't even a therapist anymore. And I was able to remember the answers to everything. And I didn't even have access to their chart anymore. It blows my mind. The other thing that this woman on I Don't Belong Here said, she's probably like, I don't even know this chick, but I'm all shouting her out 3 times. What we're seeing, that's what it was. She said, what we're seeing in this trial is some of these providers are covering the institution's ass. The institution isn't going to cover your ass. And that's where the whole I can get a new job, I can't get a new license comes in. You're in a position of trust. You should just be honest. This is one of those things that I struggle with. Not everybody is like me. I would rather quit my job and go somewhere else or risk getting fired because I did the right thing and I said, no, that's not how it was. My supervisor told me to do this, because continuing treatment isn't necessarily the same thing as receiving effective treatment. And I think that we see this in this case. She was continuing her treatment, but was it effective? She was needing a higher level of care by some of her own providers' recommendations. I have the original DSM-5, but I think it's DSM-5 TR. And one of the other issues being discussed because of this case that I think needs a little clarification is, you might have heard some people say postpartum psychosis isn't in the DSM-5. There is an important piece of truth in that statement. Postpartum psychosis is not presented as its own standalone DSM-5 TR disorder called postpartum psychosis. Don't hear that and walk away thinking postpartum psychosis isn't real, because that's two completely different statements. Postpartum psychosis is clinically recognized. The American College of Obstetricians and Gynecologists, ACOG, specifically addresses acute psychosis occurring during pregnancy and postpartum in its clinical guidance. Even though it's not in the psychologist's handbook, the DSM-5, it is clinically recognized in the field of obstetrics and gynecology. Just because it's not in the big book of mental health does not mean it does not exist. The ACOG also instructs clinicians to provide immediate medical attention for postpartum psychosis. And my source on that is the ACOG Clinical Practice Guideline number 5 and the ACOG Perinatal Mental Health Patient Screening Guidance. Diagnostic classification and clinical recognition are not the same thing. That this distinction matters enormously. The question shouldn't simply be, can I find these exact words listed as their own diagnosis in the DSM? The clinical questions should be, what symptoms is this patient experiencing? What could those symptoms represent? And are those symptoms changing? Are they becoming more severe? What are the risks? And what level of intervention does this person need? Higher level of care. That's an intervention. A condition doesn't suddenly become harmless because it doesn't have its own standalone heading in the diagnostic manual. How mental illness does not always look like a crisis. This has been another source of contention with those of us watching the case. We hear the prosecution say, did she seem like she was in her right state of mind? It's really important to understand that mental illness doesn't always look like crisis. A seriously mental ill person doesn't necessarily look like our cultural stereotype of somebody in psychiatric crisis or our Hollywood stereotype of someone in psychiatric crisis. Somebody might be able to hold a conversation and answer questions and even complete tasks and take care of responsibilities and even tell you that they're okay. They appear completely rational. That does not automatically tell you what's happening inside of their minds. And I say this as somebody who interacted with somebody in a full-on blackout that they have no remembrance of. Mental illness does not always walk into an appointment screaming, hey, hi, I'm a psychiatric emergency. No. Sometimes it walks in exhausted. Sometimes it appears as, I can't sleep. I don't feel like myself. Something is wrong. I can't get out of bed. This medication doesn't seem to be helping. I'm scared. I'm obsessively Googling symptoms online because I know something's wrong with me and I can't figure out what it is, which in and of itself might actually create the condition to be worse. But they don't know that. They're just trying to get help. Sometimes mental illness is just one piece at a time. Sometimes it starts off with lack of sleep, and then the next thing you know, it's a bipolar manic episode. They're awake for 3 days. Clinical assessment is so important because we need to notice these changes as providers. I understand that I am not a provider and I am not licensed. That's why the whole disclaimer, this cannot be a substitute for therapy, okay? Everything we're saying here is educational, informational, and alleged. The provider has access to something the patient doesn't necessarily have. clinical training. The patient brings you the pieces, and it might be one piece at a time. Part of the clinician's job is determining what those pieces mean and how to put them together to figure out how to best effectively treat that patient. It's really imperative to understand that even with screening, because you see screening a lot, you'll see it especially in emergency rooms, and you're even seeing the DV screenings now. Do you feel safe in your home? Do you have enough money? Do you have enough food? Are you feeling suicidal or homicidal? That is not a treatment. Screening is to see if this person needs more help or not. This is where the ACOG's recommendations become particularly important. ACOG doesn't simply tell healthcare professionals to screen women for mental health problems during pregnancy and postpartum. Its guidance says mental health screening should occur with systems in place to ensure timely assessment and diagnosis, effective treatment, appropriate monitoring, and follow-up based on severity. Those words matter. Assessment, diagnosis, treatment, monitoring, follow-up. This is supposed to be a continuum. There's this new buzzword that came out right around the time I freshly graduated from my master's program, which was continuum of care. It needs to be a circle, not a line. Sometimes somebody just briefly needs mental health help, and sometimes they need lifelong mental health help. It's not always going to be, boop, we're done. It's going to be a continuing circle because healthcare loves their screening tools. We love questionnaires. We love assessments. We love asking patients to tell us what's happening. Some of us even know when our patients are lying to us. We're able to assess that even though their answers on our assessment are different than how they present. Identifying a problem is not the same thing as treating a problem. Documenting that someone answered a question isn't necessarily the same thing as clinically evaluating what that answer means, and that's what I'm talking about. Just because you tell me you're not suicidal doesn't mean that I can't tell you're in distress. That's the whole point of why face-to-face matters. And it's also the whole point of why, are they shaking their leg? Are they biting their nails? Do they seem distracted? Are they staring off into space? Are they making eye contact with me when I talk to them? That's why those things matter. And it's harder to tell when I'm looking at a camera if I'm making eye contact with you, because my camera's right here, but my screen is right here. So am I making eye contact with you, or am I just looking at my screen? Documenting someone answered a question isn't necessarily the same thing as a clinical evaluation of what that answer means. And this is why I'm constantly talking about providers doing their job correctly. I'm not demanding perfection. We are not perfect. I am not demanding clairvoyance, but patterns matter. And if you have a pattern of missing steps or cutting corners, that's not going to go well for you when your client ends up in distress. Suicide risk is not a yes or no question. Just because I ask you if you're suicidal and you say yes or no, doesn't mean we just end there. That's again where this clinical evaluation plays a role. I think the public seems to sometimes misunderstand that suicide assessment isn't simply, are you suicidal? Yes, no, okay, moving on. ACOG's guidance says that when someone answers a suicide or self-harm screening question affirmatively, the clinician should immediately assess the likelihood, the acuity, and the severity of suicide risk and then arrange management tailored to that risk. It's the same for clinicians. Have you ever had previous attempts? Are you getting along with your family right now? The care has to be tailored to the individual person, and that is also what makes being a therapist so much different, because what works for this person might not work for this person. There is an average person. Mental health does sit on a spectrum. There is your average client, but you're always going to have your outliers. I'm an outlier on the I only need to go to rehab for 90 days and I've never been again since. Then you have the other extreme, the person who's in and out of inpatient for not taking their medication. Then you have your average person. This is your person who they're compliant in their care. Maybe once in a while they have a flare up and they have to go inpatient, but they're compliant in their care. And compliant in their care means they're showing up, they're taking their meds, and they are doing everything they can to try and just get through the day. That's literally the bare minimum that some can do. Assess means screening questions. This means a screening question that is designed to give you information. Clinical assessment is going to determine what that information means in the context of this particular human sitting in your office. What changed? What's happening right now? What's the trajectory? What are the risk factors? What are the protective factors? What does recent history tell us about this person? Has their behavior changed? Were they always happy and jovial and now they come in and they just can't wait to get out of your office? Are they complaining that they're exhausted? Are they complaining they're not sleeping? Are they complaining about nightmares? Has functioning changed? They used to come in all clean and well kept. Now they're coming in unkempt and dirty with stringy hair. Has their thinking changed? Do they make sense when they talk? Is their speech rapid? Is their speech slow? Has the family noticed? Do they have a family member coming in with them and saying this, that, or the other? In Lindsay Clancy's case, her husband was reporting things. What does that collateral information tell us about this person? What happened since their last appointment with us? Sometimes the clinically significant information isn't one answer, and we have to ask those probing questions. I was thinking about this when I was watching Mr. Reddington. One of the things I noticed about Mr. Reddington that he does, and I was noticing this is a similarity to mental health treatment. Probing questions. You have to ask probing questions. He will say, did you do this? Did you do that? Did you do this? That's what you as the therapist should also be doing when you have a client in your office that's presenting differently or they're new to you. The pattern is going to become recognizable to you as the clinician the longer you treat this client. You're going to notice the changes in their mood. Before we get to the next part, one of the other things I want to address that I think may have played a role, it really just depends on if she was insurance or self-pay. And even then, I think it might even depend on the institution in which she was being treated. When I worked in a clinical setting for a nonprofit, they only took Medicaid patients. They would take private pay, but you had to pay out of pocket and ask your insurer to reimburse you. So they would take private insurance, but they didn't really. For the most part, they took Medicaid clients. And I think one of the biggest issues in this country, and I will say it till I'm blue in the face, is the way Medicaid insurance is exploited. And Arizona particularly has been busted more than once with this issue, especially with Native American clients. One of the ways they exploit, there's many, besides picking up people in New Mexico, saying they'll put them in treatment and then dropping them off in the streets of Phoenix, giving them alcohol and leaving them homeless, but billing their insurance. Besides that type of actual fraud, one of the issues I noticed is Medicaid is exploited by these, especially nonprofit mental health places. My experience only, and this is all alleged educational in my experience. I can call Timmy's mom and talk to her for 5 minutes about Timmy's progress because Timmy is 9 years old. And I get the bill for 15 minutes to Medicaid. I can sit Timmy down for an intake because he needs care and he's establishing care with us and we have to get a full understanding of him as a patient. And it might only take me an hour to do that intake, but I get to bill for 3. Productivity, that's what they call it. The goal at the end of the day is I might only see 6 clients, but I need to bill for 10, 12, 13 hours a day because that's how we get paid. And I'm sorry, but I think that's a scam. You're not putting the patient first. You're putting money first. How are you a nonprofit and you're not putting the patient first? I understand we have overhead, but as a nonprofit, you can get grants, you get people to donate. You're a nonprofit. You can raise funds a million different ways. You don't have to scam Medicaid. And there are people who might think that's a hot take, and I don't care. I think it's bullshit that I can call Timmy's mom for 5 minutes and bill for 15. I think it's bullshit that if my intake takes an hour, I can bill for 3, even though it only took me 1 hour. That's stealing. And that's also part of what contributes to this system of crank them out, instead of actually being patient-centered. And I believe that mental health should be more patient-centered than it is. And we see this in all the institutions. I don't know how the VA works as far as like billing goes, because they are my insurance. I've had mixed experiences. I've had where it's just crank me in and crank me out, hurry up, hurry up and see me and get out my door. And then I've had some who really want to take their time, and I know their caseload is heavy and I feel like I'm taking too much of their time. Then I've seen where some of them just show up for the check or something. I'm not sure. They show up and they don't do anything. They don't do a risk assessment. They don't even do proper therapy. It is what it is. I think we can't expect perfection. People are going to be people in every field. We're always going to have somebody who's an overachiever. We're always going to have somebody who does just the standard. And we're always going to have the underperformers. What's happening is I think sometimes we're keeping the underperformers because we are so taxed in the mental health field. You have people like me who we get burned out and frustrated, and we don't want to fucking be in the field anymore because it's really annoying to see how insurance will let me bill for a 5-minute phone call, but they won't justify the stay as somebody who's only been stable for a short amount of time. I always say insurance will jump over $1 to save a dime. This is not to glorify what Luigi Mangione did, but we have this whole debate about, oh, he killed this guy in cold blood. Okay. And United Healthcare, how many lives have they cost by denying 33% of the insurance claims that have been put in? Kind of arguing the same thing on both sides. How many lives were lost because of this one person? That does not mean what he did was the right thing to do. I'm not saying that. But this is how we get here. The system is fucking broken. Andrea Yates, the United Healthcare shit, Lindsay Clancy are all great examples of how the system is fucking broken. The VA is another great example of how the system's broken. It's not designed to be the way it is. It's actually designed very well to work. It's just not working the way it's supposed to. Why? I don't know. Random thoughts. Okay. Who owns the whole patient? And this question might be the most important question from the entire case that actually bothers me the most. What happens when somebody has multiple providers? One provider's handling the medication, another provides therapy, another evaluates the person at a hospital, another is changing a medication, and someone else sees the patient afterward, and then everybody has different pieces of information for the same client and nobody's talking to each other. Personally, I think that all health should be integrated into insurance, period. It should be a whole health system, meaning your mental health affects your physical health and your physical health affects your mental health. Your vision and your dental, those also affect your mental and physical health. And I don't know why they are treated separately. I really hate that you have to have dental insurance and vision insurance, and then your health insurance only covers a portion of mental health. They all should be working together, quite honestly. It should be integrated. It should be an integrated system. And I actually really love integrated systems. This is the one thing I will say the VA is doing correctly. And everybody says, oh, it's communist healthcare. Well, guess what? I was in the military and now I'm a veteran, and the healthcare system is communist if that's how you want to see it, but it's integrated. And so your vision and your dental, and we don't even get vision and dental in the VA unless you're 100% disabled. Even they have their limits. However, this is the one thing they're doing correctly. All the providers can see what other providers have prescribed or done in the EHR itself. Okay, so if I go to the dentist and he knows that I'm on Vicodin because I just had surgery, then he knows I probably shouldn't prescribe her Vicodin. I'll just give her an analgesic instead. If I go to my mental health doctor and they give me prazosin to help with nightmares at night, because that's an off-label use for prazosin, and my doctor sees I have high blood pressure, but they can also see I'm on prazosin already, so that they're not accidentally making a mistake. That's the one thing I will say that the VA does have correct, is that the care is integrated and everyone talks to each other. And if we want to go to an outside provider, let's just say I have a crisis and I can't get to a VA hospital and it is life, limb, or eyesight, and I go to my local hospital. If I want the VA to pay for that treatment, I have to allow them access to those records so they still get to see what was done, what was treated, what needs, whatever, right? Even if they don't agree or want to provide those same medications, they can still see what I was treated for, what I was put on, and what the treatment plan, discharge plan, all of that was. Our country would benefit from that as a whole, but unfortunately, the insurance system is part of the problem with the healthcare system, the way it currently stands in the US. There's been a lot of people with great solutions, and everybody has something to say. And at the end of the day, somebody's going to be angry no matter what you do. So you should just maybe do what's better for the greater good. And if you think that's communist of me to think, then that's communist of me to think. I don't care. I believe that everybody deserves basic health care. Who is most in charge of that patient's care besides the patient? Testimony in the Clancy trial has raised questions about communication between providers and how much information individual clinicians had about treatment being provided elsewhere. The Associated Press, reporting on testimony concerning psychiatric nurse practitioner Rebecca Gelada, described questions about whether she possessed complete information from other clinicians and whether she had communicated with other providers and hospitals involved in Clancy's care. Other trial reporting has discussed concerns raised by a specialized treatment program regarding Clancy's medication regimen and questions surrounding communication of those concerns. Again, I am not saying this provider caused the deaths of those children. I am not saying this was malpractice. What I am saying is look at the system. Look at the system as a whole. Imagine being that patient. Imagine that patient was you. One provider knows this, another knows that, and the hospital knows something else. A specialized program has a different concern. One person changed one medication. Someone else prescribed a different medication. And somehow we're expecting Lindsay Clancy, who was the person experiencing the psychiatric crisis, to make sure everybody knows everything. Think about how backwards that is. The person experiencing severe mental illness may be the person least capable of functioning as the project manager for complicated healthcare. Yet sometimes that's exactly what we're asking them to do. Tell this provider what that provider said. Bring these records. Call this number. Schedule this appointment. Especially if they don't have somebody assisting them with those. Remember these medications. Explain what happened 3 appointments ago. My biggest beef was when we would discharge a patient who couldn't even remember to take their medications because they were stable. Like every day, literally, we would have to remind them, you've got to take your medication. But the insurance would want to discharge them. Like they cannot function without somebody telling them to take their medication. It is costing society and it is costing healthcare in the long term more money by not putting these people in treatments that are effective for them. And I get it because of the insane asylums and all that stuff back in the day. We want the least restrictive care possible, but there are the outliers that need a different type of care than your average person. And I think that's what's forgotten in all of this. Tell your therapist what your psychiatrist said. That's not your job. They should be talking to each other, especially if they're in the same network. Tell your psychiatrist what your therapist thinks. At some point, somebody with healthcare system has to ask, who is connecting the dots? Now I want to talk about how providers do not work in a vacuum. When I talk about provider accountability, I am not anti-provider. I'm actually quite the opposite. Good providers deserve systems that allow them to be good providers because they are not always the ones at fault for these failures. Mental health professionals are human beings working inside the systems that can be overloaded, fragmented, bureaucratic, understaffed, and rushed. A therapist cannot coordinate care effectively if the organization doesn't give them time to coordinate care. A psychiatrist cannot perform a thoughtful evaluation if the business model expects complicated psychiatric patients to move through appointments like an assembly line. This is where I was going with my comments earlier about how productivity in some places, productivity for billing purposes, is more important than patient-centered care. A provider cannot magically know what another clinician documented if records are not accessible, have not been transferred, have not been reviewed, or nobody has clearly taken responsibility for coordination. Accountability has to exist at 2 levels. Individual professional accountability is one, But the other is systemic accountability. Saying the system is broken cannot become an excuse for poor professional practice, but blaming one exhausted clinician for every failure created by a dysfunctional healthcare organization isn't going to fix anything either. We need both conversations. It's never going to be a perfect system. We can allow room for grace. The problem with that is sometimes allowing that grace is going to have devastating consequences. In Lindsay Clancy's case, I don't feel like this was just one person made a mistake. I feel like this was failure after failure after failure. It is one thing for one clinician to fail one client out of maybe 100. It is another for multiple clinicians to fail one client. That's just my opinion. Was it the way their systems were set up, where they worked? I just think we, especially because we as healers, sometimes we really passionately care about what we do, but sometimes we get burned out too. Are we taking care of these providers? Are they getting time off? Are we demanding they have these 100-person caseloads because the system doesn't have enough providers? Well, one of the reasons the system doesn't have enough providers is because try asking for time off at some places. I've been there. Sometimes you can't get the time off. Sometimes people want to argue about the time off. If you call in sick, they want to argue about that. Well, someone else is going to have to take your clients. Like, I get it. I get it. It is tough out there. But a lot of these issues can be solved if we really explore different solutions. If we stop focusing on the money aspect. I understand we all got to eat at the end of the day. I understand overhead. I understand that there's a very low profit margin in healthcare. There has to be a better way. It can't be good for the profit margin to pay for malpractice suits because that's going to raise somebody's insurance. We need to have conversations around both the providers and the systems they work in, because are they unable to do their job because of the system, or are they doing their job and the system is failing to audit? I've probably shared bits and pieces throughout this conversation today, but it's personal to me. This is the part of the episode where I'm going to get personal without discussing details that do not belong in this episode. Mental health accountability has become incredibly important to me. And it has been important to me since I finished school. It was important to me before I finished school. I used to have to advocate for one of my children who my mom raised my oldest 3 kids. I own that, okay, because of my addiction. I used to have to help her advocate for the care of one of my severely mentally ill children. And the system failed him too. The system is still failing him. So it's personal for me. But there was a time that I believed that if someone was actively receiving mental health treatment, I could assume they were getting the care that they were supposed to be getting. I assumed that somebody was getting a proper assessment, that somebody was watching changes in symptoms, that somebody was documenting things properly. And there were times that I assumed that somebody had a treatment plan, or somebody was thinking about somebody's safety risk to others or themselves. I assumed somebody was following up when they said they would follow up, and I assumed somebody was documenting correctly. I assumed that somebody was connecting the dots. Well, shame on me, because you know what they say about assumptions, right? When you assume, you're making an ass out of you and me, and that's what I did. Because I assumed that if something changed dramatically, the level of care would change with it, because that's what I would do. That's what my colleagues would do. But I've learned that as a family member, you can't always make those assumptions. Making all these assumptions and realizing that I was wrong changed me. It changed me. Because when somebody walks into a mental health professional's office or logs into that telehealth appointment, they're giving another human being access to one of the most vulnerable parts of themselves. That is an enormous responsibility. Again, providers, in a sense, are like pilots. There are people's lives in their hands. I'm not saying they're responsible for every person that walks through their door, but they are responsible for what they do when that person walks through their door. Because if you fail to assess somebody who is at risk and demonstrating signs that they are at risk, or you document incorrectly something, and that person hurts somebody or hurts their children, that's going to come back on you as the provider. I am so glad somebody taught me document, document, document. Document who you talked to, document who you reached, document who said what. And I am so happy for that, because to this date, I haven't had anybody come after me for my notes. I'm pretty confident in my note taking that should never be an issue. I expect providers to practice responsibly, and unfortunately, I sometimes expect them to provide at the same level I provide at when I was providing, which was document correctly, assess risk. If something doesn't seem right, address it. Don't just let it go. No matter how tired, no matter how burned out I was, it's weird. If somebody was in crisis or I thought they were in crisis, I actually did a better job at making sure that whatever they needed was addressed. I felt good about doing my job and doing it correctly, right? Because I'm a healer. At the end of the day, I'm a healer. I'm still a healer, just not a healer in the field. Now, I expect providers to practice responsibly, and that's any provider, doctor, nurse, patient care tech, whoever you are, you have to be responsible. You are in a position of public trust. I understand. Clinicians cannot predict every suicide. When somebody presents better after a while and then they commit suicide, they tricked you too. They tricked you too, because sometimes, you know how you'll hear families say, oh, but they seem like they were doing better. They cannot prevent every tragedy, and I understand that. They cannot read minds. They cannot guarantee outcomes. Sometimes horrible things happen despite excellent treatment. We have to acknowledge that. We have to acknowledge that. But acknowledging those limitations does not mean it's okay to abandon professional standards. It just means that asking, was reasonable assessment performed? Were concerning changes investigated? Was there appropriate follow-up? Did the documentation accurately reflect what happened? These questions should have the answer, yes, behind them for the clinician. Did escalating symptoms result in reconsideration of the level of care? If somebody is asking for help, they know they need help. Was the treatment plan reassessed when the treatment wasn't working? If you have a provider feel like treatment is not effective, did you reassess that treatment plan? Did you reassess the modality? Did you reassess with the client? Maybe we're just not working together well. Maybe it's a me problem. Should I ask them, do they think they might be more effective with somebody else? Those are not attacks on mental health professionals. It is okay to admit that not every client is going to click with you. I don't click with every therapist I've ever had. I've had to change therapists a couple of times over the course of my life. The standards protect providers too. Those standards are designed to protect the patient and the provider. So the providers cannot be lost in this either. I also want to talk about how working in this field can be taxing, and providers also need support. We covered that a little bit briefly, but this is the other half of the conversation that I want to make sure is not forgotten. We cannot demand excellent mental health treatment while creating healthcare systems that make excellent healthcare treatment almost impossible. Providers need manageable caseloads. They need adequate appointment times. They need competent supervision, and they need continuing education. We can't just be death by PowerPointing our way through a checklist saying they were trained on this or that. I personally believe supervisors should be seeing at least 1 or 2 patients on top of supervising their clinicians. I think it keeps them active in the field. I think it also helps with continuing education and trends that are changing, but I also think it helps with auditing charts. Just my opinion. But even if you don't do that, providers need access to patient records. They need to be able to access patient records if you think they might be seeing multiple providers. They need functioning referral networks. They need clear emergency procedures. And they need time to communicate with other professionals. If one person would have called the hospital and said, hey, I really think she needs to be admitted, even though she's saying she's not suicidal, could that have made a difference? We'll never know, right? But could it have? We don't want to be reactive. We need to be proactive. They need enough time, doctors, providers, mental health people, whoever in the field, they need enough time to actually read the chart. If you're getting somebody and you can only read the chart for 5 minutes before you see them, you're doing the patient a disservice. There has nothing been more annoying to me than going to see a provider and they know nothing about me. You're telling me that you didn't have 5 minutes to read my chart. That's a systemic issue, because you could have at least got to know how old I was and what I'm here for. Providers need organizations that value clinical judgment as much as they value productivity. When a provider says this patient needs a higher level of care, there needs to actually be a higher level of care available, and insurance needs to stop being the deciding factor. If a physician who has gone to school to make these decisions states someone needs to go to a higher level of care, or a psychologist, therapist, whoever has gone to school to make this assessment, we need to stop treating every referral as if it is insurance fraud. If somebody needs a higher level of care, I'm going to try to get them there. I'm not going to refer somebody to a higher level of care that doesn't need to be there. And I have before said, client wants inpatient, they don't need inpatient. There needs to actually be a higher level of care available. We need to stop limiting higher levels of care and just bouncing people as soon as they're stable, because sometimes that stability is temporary. And this is where hospitals come into this conversation. This is where healthcare organizations and insurance companies need to come into this conversation. Administrators, policymakers, people that are passing these policies have no concept of what they're actually passing. Sometimes they don't even understand that the policy they're passing in theory should work, but it can't because we have this hiccup and this nuance and this hiccup. Licensing organizations need to be part of this conversation. One of the other things my clinical supervisor when I was interning taught me was listen to those board meetings, because there's going to be a lot of examples of what to do correctly and a lot of good examples of what not to do. And she was not bullshitting. And I'm going to tell you one of my favorite meetings to listen to of the Arizona Board Behavioral Health. I don't even know if this woman is still on the board. She looked like Nancy Grace, but she was a lot nicer. And she said, I hate community care systems because they're overtaxed and they just crank them out, and they don't focus on treatment. They don't focus on treatment. They focus on numbers. Like, how many do we get in? How much could we bill? And I loved that she said that, because I see it exactly the same way. I was watching a meeting where a woman had signed the client's name on the treatment plan because it had to be signed, and it didn't get done because she didn't have time. And so she just signed it because she didn't think anybody would know. And then they did know, and she was in there answering before the board about her license. This is why I say you can get a new job, you can't get a new license. It had to do with the pressure she was under for the agency she was working in. Imagine being under that kind of pressure. You've gone to all these years of education, and because your agency doesn't give you enough time to meet with patients and you missed a signature, you sign that signature. I don't know if she felt pressure to do it, if she chose to do it on her own, if somebody suggested she do it. I don't know. What I do know is nobody should ever have to be under that kind of pressure as a provider. This is a soapbox I could stand on all day. Healthcare payers, which is also insurance, because burnout is not just something that's going to affect the clinician. Fragmentation is not just something that's inconvenient, and understaffing isn't just an annoyance. Poor communication is not just inefficiency. All of these things can become patterns, and if they're daily patterns, they can lead to patient safety problems. And it's going to cost a lot more in legal fees and everything else than it probably would be to just address the problem as it happens. We need to be supporting them in their workplace, but we also need to be holding them accountable. And that's not a competing thought or a contradicting thought. You can support a provider and still hold them accountable. They're connected. These are interconnected. They're synergistic. I want clinicians to have everything they need to do their jobs correctly. They deserve that. They went to school because they care about the field that they studied to get there. They also need their employers to allow time off, allow time for documentation, allow time between appointments, and not to have caseloads of 100 or 200 clients. I had a job where I had 110 clients when I left the job. I lasted at that job 9 months. That should never happen. And part of that had to do with the productivity issue made it a very toxic workplace because it wasn't about families and patients getting better. It was about, did you bill enough? Did you bill enough? Did you bill enough? I went from a job that was only supposed to have 30 people on a caseload to 110. I left and probably left someone, they had to split those among who was left. And I felt horrible about it. I felt horrible for my patients and I felt horrible for my colleagues, but I could not mentally handle it. And that is part of this systemic issue. And when the system fails, providers become more vulnerable to failing their patients. And ultimately, patients and families, they pay the price, like those 3 children in this case. There's another side of this case that I think if we're going to have an intellectually honest conversation about Lindsay Clancy, we need to talk about the evidence that doesn't fit neatly into the narrative that I've been discussing. Several providers who treated Lindsay have testified they did not observe psychosis during their interactions with her. Providers have also testified that she did not report hearing voices or intentions to harm her children to them. The prosecution is arguing that Lindsay was not psychotic when she killed her children, and they point to behavior they contend demonstrates planning and purposeful action. The defense sees evidence very differently. They argue that severe mental illness, including postpartum psychosis, profoundly affected her mental state. Those disagreements are exactly why there's a trial, and I'm not going to resolve them here. You don't have to believe Lindsay Clancy's insanity defense to believe her treatment deserves some sort of further examination, because those are separate questions. A jury can ultimately reject the insanity defense, and we can still ask whether postpartum mental health care needs improvement. We can still examine the fragmented healthcare that she experienced, and we can still examine the provider communication or lack of communication. We can still talk about the medication monitoring that she should have been getting, and we can still talk about suicide assessment. We can still talk about continuity of care. We can still ask whether our healthcare systems adequately support the professionals responsible for managing complicated psychiatric patients. What does get help actually mean? And this brings me back to where we started. We tell people get help. Maybe our mental health conversation has focused too heavily on people getting through the front door, because getting someone through the door isn't the finish line. It is just the beginning of that journey. If somebody reaches out, there has to be somebody there to listen. There has to be somebody there to assess. And there has to be somebody there who can monitor and follow up with that person. There needs to be someone who can communicate and notice when treatment is not working. And that someone needs to be willing to change course. Access to mental health care is not necessarily the same thing as receiving effective mental health care. That is my thesis for this episode. If we're serious about mental health advocacy, we need to be willing to talk about both. At the end of the day, there are 3 beautiful children who should still be here: Cora, Dawson, and Callan. 2 families are going to live with what happened for the rest of their lives, and no verdict will undo that. And while we're talking about verdict, I want to address the fact that the defense has stipulated to several things, because she's essentially trying to defend herself, really just to see if she can go into a hospital, right? Not to jail. So she didn't have to admit guilt, but they stipulated to several things so the prosecution would not need to bring them up. Because if you've been following the trial, there have been several days where Lindsay is just crying throughout the trial. That tells me a lot of what I need to know about her and who she is as a person. You don't see that very often in trials, and that's all I'm going to really say. It has been alleged by some people watching the trial that the prosecution is trauma farming, and they are continuing to put on witnesses they don't need to put on, because the defense stipulated already to those things so that they could try to avoid her crying, right? Because at the end of the day, we're trying to keep the jury unbiased so they can make an informed decision. So the defense felt, okay, we'll just stipulate to this, and the jurors will get to see the stipulation and what they're stipulating to. And the prosecution is still continuing to put on witnesses that don't need to be on due to that stipulation. It's being alleged that that's trauma farming. And I'm going to say, I have to concur with that, but not only that, my opinion is they're losing focus, not only of the three kids, but they're so focused on the win that they're forgetting about how that jury is going to experience vicarious trauma from this case. And what they are doing is not actually helping the jury. It would probably benefit the jury as well to not have to see all these excess witnesses and just understand that Lindsay stipulated. And in a way, I feel like if they did that, people would view this a little bit differently on the prosecution side. Some of the stuff they've showed has been, or talked about and discussed, has been extremely graphic for the layperson. And I just don't see how overindulging in the graphicness of that is going to benefit the jury, because it does feel like they're trying to push this as emotional. And usually on a jury, you're instructed that this isn't about emotion, this is about reasonable doubt. Whether Lindsay goes to jail or she's in the hospital, she's in a life of eternal torture at this point. Do we need to really make it worse? No verdict is going to undo any of the things that led to this place. Guilty or not guilty, no verdict is going to undo that. The jury is going to eventually determine whether Lindsay Clancy was criminally responsible or not. And regardless of what that jury decides, I hope the mental health community asks themselves the question about what can we learn from everything that happened before January 24th, 2023. Not because we need somebody to blame, but because we need to know where our intervention could be better and where communication could be better. And clearly something needed to be better here. Maybe it was assessment, maybe it was medication monitoring, maybe it was really taking postpartum mental health seriously and becoming more educated on postpartum mental health. What role do hormones play in postpartum mental health, especially if a mother is breastfeeding? One thing I've noticed about the recovery community, or at least some of them in Arizona and Nevada, is they have peer support, but they also have what they call navigators. And these navigators help people navigate the system. What services are you able to get? They sort of act as a liaison between the patients and the agencies. I think they're kind of an advocate, honestly. The patients can go to them and say, I'm having this issue, and that person can help them navigate the system. And it's usually a peer. It's usually somebody who's been in recovery or had mental health issues, and they've been in a period of recovery for X amount of time. Even with systems not being perfect, even with them some falling below the standard, I'm going to continue telling people to ask for help and don't quit. You're going to be your own best advocate. And if someone you love is struggling to advocate for themselves, find them an advocate, please. Find somebody who will fight for them if it can't be you. Don't ever stop asking for help, please, because healthcare systems do have a responsibility. On the other side of that sentence, ask for help. And when somebody asks for help, people deserve somebody who listens, because I've seen where mothers ask for help and they're criticized and shamed for that. And then we have on this side, she asked for help and she still didn't get it. And then we have where people don't ask for help because of the shame and the stigma. And at the end of the day, everybody loses. When that happens, everybody loses. Society as a whole loses. In the military, we used to do this thing called after action review. This warrants an after action review. What should have been done better? And I hope it's been done already, but if it hasn't, it should. Advocating for mental health cannot only be about convincing people to seek treatment. It does no good for them to seek treatment if they're not feeling heard. It also has to be about making treatment worthy of the trust we are asking people to place in it. That's why I care about provider accountability. That's why I'm talking about Lindsay Clancy today. Not because I know what the verdict should be, because I don't. Get help can't be the end of our responsibility. It has to be the beginning. All right, if you stayed with me this long, thank you so much for joining me today and listening to me. I feel like this is an important topic, and I would love to hear your thoughts and comments below if you're watching on YouTube. If you're on Apple or Spotify, do me a favor and give me a rating. This is going to help me get out to more people. I look forward to our next episode.